Welcome to the last scientific session, hence best scientific session of the meeting. Thank you all for sticking it out. You're awesome. We have a great session this morning. Dr. Agastron from New York, Kara, asked me to announce that at the end of this session, as part of the closing gestalt, or that's not the right word, but part of the closing ceremony, Gail Onyx of Toronto and formerly of Michigan is going to interview Dr. Bartlett about 50 years of all of our craziness. So that should be really exciting. And I'm Tom Brogan, I'm from Seattle, and next year the meeting is going to be in Seattle, and we have a lovely city who is very open to all visitors, foreign and domestic, and we would love to have you all come. So please come and bring all of your friends. It will be great. And right now, our session on pediatric respiratory issues in ECMO, we are going to skip Dr. DiNardo, and we're going to go to Dr. Joseph Kone, who is at the University of Michigan. He's a pediatric intensive care doctor, and he's going to talk about the very important issue of tracheostomy in children. And he's a very kind person with roots in the Midwest. He's from the United States. He's the middle part of the country. And he's a lot smarter than I am, so you'll learn more from him than from me. Thank you.
Thank you. Don't feel too disappointed. Matteo will speak here soon. He's just catching his breath after getting stuck in the elevator, so we're just going to switch up the order of things. So thank you again for the opportunity to give the talk this morning. I have no disclosures. So a lot of the data that I'm going to talk about here this morning is based on, comes from two papers that we recently published that, so really thank you to the ELSO registry for providing this data and for giving us the opportunity to look at the data here. So if you're looking to take a deeper dive into these, this would be the first place to start. So when I start to talk about pediatric long-run respiratory ECMO, it really does kind of feel a little niche and like these patients are outliers, but I think in the ELSO registry data that we pulled, there were around 3,700 patients, which was exactly the same number of patients in that time in the US that received a kidney transplant. So this is an important population that's really not on the margins. This is a true and important population that we are following. And so why consider tracheostomy in this population? And so much of the data that kind of supports this comes from a non-ECMO adult ARDS population. And so I think the first 2 points are fairly well established or evidence-based in that group of the ability to reduce sedation and improve mobility with kind of a consideration of an early tracheostomy. I think the third point of reducing the duration of critical care support in a non-ECMO population, I think is potentially a little bit more controversial in early versus late. And then in the ECMO population, I think the data is primarily based on kind of case series and description so far. I do want to highlight this study from ECMONet, so led by Dr. Schmidt. And so this is in an adult ARDS population, and they looked at an adult ARDS ECMO population, and really to look at to see whether we are achieving those goals that we're setting out for. And so when they looked at receiving a tracheostomy during ECMO support versus receiving a tracheostomy after ECMO support, did we achieve our goals of reducing the sedation that the patients receive, reducing their need for analgesia, and then achieving a more wakeful state? And as you can see in the kind of red bars there, in the population that received a tracheostomy after ECMO, it did seem like they were better able to achieve those goals than in the population that received a tracheostomy during ECMO. So then when we look at kids, our kind of experience and approach to this is very different than the adult experience. And so in the study that we did, out of the 3,685 children, there were only 94, so about 3% that actually received a tracheostomy on ECMO, whereas in the adult COVID-19 experience, it was 32%. And when you look at the children who receive a tracheostomy, they start to resemble more of that adult population. And so the median age in the total cohort was around 2 years of age, and in the population that received a tracheostomy, it was around 15 years of age. And the primary support in most of those patients that did receive a tracheostomy on ECMO was either VV or a conversion. And so this is, I think, a different population than what we think of as our typical childhood respiratory failure. So when you look at the timing of tracheostomy in this population, so I've just plotted those 94 patients and when they received their tracheostomy during their ECMO support, it really is can be at any point during the run. And I think when you look at the timing of tracheostomy, I think it does start to highlight some of the kind of general themes or ways that we approach tracheostomy in pediatric ECMO. So within that cohort, the patients that received a tracheostomy at less than 14 days, really I think this is kind of an approach that in an adult type patient, so in a median age here was 16 years with primarily VV support that had a shorter ECMO run, that this is kind of a primary approach of this is a patient early on in the run, you decide that a way to facilitate their rehabilitation and support will be to place a tracheostomy. And then I think there's also a population that this is important when we're looking at outcomes after this group that is in the later tracheostomy, so the tracheostomy after 14 days, where we've tried a lot of other things, and now it seems like there is a need to try something else. And so tracheostomy may be a way to facilitate a more wakeful state and rehabilitation. And so this is starts to look like a younger population with more conversions and potentially VA, and then the duration of ECMO support and mortality in this group is much higher. So what are the outcomes after tracheostomy? So I did start to put asterisks on this slide, and then I had to do an asterisk on every one. So I think it is important to look at this in a lens with some nuance. And so, I think the biggest and the most feared complication of doing a tracheostomy at ECMO is going to be bleeding. So within the ELSA registry, the surgical site bleeding for a pediatric patient is going to be requiring greater than 20 per kilo transfusion or potential surgical intervention. And so when we're thinking about 20 cc's in a 10-kilo baby on the bed is very different than 20 cc's of blood in that patient's airway. And so I think this is a little bit limited, but overall after tracheostomy, and this isn't specifically tied to the tracheostomy within the registry, so again, another asterisk, but it seemed like around 12% of these patients did have a documented surgical site bleeding complication, which I think fits with the roughly around 10% experience described in the adult literature. Mobilized on ECMO, so there definitely were more patients that received a tracheostomy on ECMO that were able to be mobilized. However, I think if you also look at this in another lens of we are placing a tracheostomy in these patients for the goal of mobilization, and we only achieve that goal in less than half that group. And so I think depending on how you interpret that number, I think also puts a little bit of a caveat there as well. And then what happens after? And so I think this is another kind of space that we are a little bit different than the adult experience. And so this was a nice study that in looking at patients that after decannulation, so none of the patients in their group received a tracheostomy during ECMO support. And in the adult COVID experience, it's roughly half, so about 51% in the study that we did had a tracheostomy during their ECMO hospitalization, and that's generally not our pediatric experience, is that it's been about 15% of the survivors had a tracheostomy during the hospitalization, and the numbers get lower for mechanical ventilated to discharge. So, and this, I'm always amazed when I come to ELSO and see kind of experiences of people doing things at the margins, and do we need a tube at all? And is even into the neonatal population, people are talking about extubating children. So I think where do we go from here? As I have alluded to, I think this is a space where I think it's a place like ELSO where you can learn from the adult experience. If there is a signal from there's a patient population that is clearly the tracheostomy is the right answer, I think we'll find that in the adult experience first before we see that in kids. And really working to identify strategies that facilitate wakefulness and rehabilitation. I think a tracheostomy can potentially be part of that strategy, but it doesn't have to be the only strategy. And then if you are considering a tracheostomy, I really think this is a space where shared decision-making carries a lot of weight, and including a kind of multidisciplinary and interprofessional discussion of can we actually achieve our goals of rehabilitation, and how will tracheostomy help facilitate those goals. And then discussing with the surgical colleagues as the kind of talk about tracheostomy yesterday, there's many different types of approaches that we can use. And so understanding the kind of nuances around the surgical approach and potential risks. So again, I just want to thank everyone, especially Elso, for providing the opportunity to ask these questions that I think have informed my care, and all the collaborators that were involved in this study as well. Thank you.
We will try to save the questions for the end of the session. Hopefully your memory is better than mine and you will still remember it when we get there. Our next speaker is Dr. Matteo DiNardo from Bambino Gesù Hospital, which is my favorite thing to say in the whole world. And he's one of my favorite people in the whole world, and we are really lucky to have him. He's going to be speaking about the care of stem cell transplant patients.
Thank you, my friend. Good morning, everybody, and thanks for the invitation to this great congress here in Boston. I have 8 minutes to summarize a work that lasted for a couple of years, and I would like to skip directly to the next slide. Okay, let's go a little bit faster to recover this time. We are going to speak about a very niche situation that is the hematopoietic cell transplantation and the advances that we had in the last 20 years in this field, not only in the hematological fields, but also in the critical care of this kind of patient. And we introduce in this expert consensus statement also the management of ECMO in patients receiving immunoeffector T cells. Briefly, in this consensus statement, we have discussed about the use of ECMO in the autologous, but in particular in allogenic transplantation, considering all the types of allogenic transplantation, including the matched-related donor, the match-unrelated donor, and the one that is much more appealing and has been used more in these times, that is haploidentical transplantation. Importantly, as you can imagine, in the last 5 years, there was a tremendous increase in the use of CAR T cells to cure patients with acute lymphoblastic leukemia with tremendous and remarkable results. And so for us, it was important to give some recommendation according to the data that we had. So it was, for me, an important opportunity to work with a great number of people. A great part of these are from US, and these people are not only colleagues but friends, and some of these are inside this room. And we collected our experience, and we developed first a steering committee, and then including people with experience in this field, not only intensivists, but also hematologists, nephrologists, and people dealing with hematological patients, we created a panel of people to vote some recommendation that the steering committee has developed. The society involved were 5, the ELSO, as you can imagine, but there was also the ESPNIC in Europe. There is the Palisi and other societies, including also societies regarding the bone marrow transplantation. The methodology that we use in this manuscript is the Quaker-based methodologies approached, and considering the lack of consistent paper on this field, we thought it was appropriate from a methodological point of view using the AGREE reporting to provide this recommendation. And we had, at the end of our work, 36 recommendations, 31 reaching strong agreement, and the one that did not reach strong agreement at the first voting were rephrased and by definition received weak agreement at the second voting. Summarizing the main results, when to use ECMO in this kind of population. First, we need to consider that we all strongly recommend the use of ECMO in children with, of course, not malignant disease, but also with malignant disease with chances of recovery and at low risk of recurrence. Now, it is important to work collectively with the hematologists to understand really well the chances of relapse. And to avoid biases, we knew in advance that there are scores that can help the prediction of this relapse, and we suggest to use these scores to have a better opinion, not biased by experience on this. Of course, and we reach on this the weak agreement, we didn't have a strong agreement, and instead we had a weak agreement regarding the percentage of survival or expected survival in this patient. So arbitrarily, we define that patients that do not expect a 30% survival, disease-free survival after 1 year, should not receive ECMO. Other things to consider. ECMO in this field, hematological field, is not the device that we are used to consider that helps us to have long run. We should win the battle in at least 10-15 days, because more time you spend on ECMO, there is an increase in complications, and this is important to understand in advance. Based on this consideration, is it important also to evaluate at the time of candidacy if there is other organ insufficiency, because it's preferred to use ECMO only when there is or lung and heart failure contemporary. Increasing the number of organ failure is associated, as you can imagine, to worse result. We do not have any data regarding the use of ECMO in disease associated to transplant, so pay attention and be careful when you evaluate a patient with sinusoid obstruction syndrome or microangiopathies, because this can complicate your run. A couple of words regarding the evaluation of patients receiving allo and autologous transplantation. A recent paper of one of our colleagues, Taylor Olson, said that there are no associated risk in terms of mortality if you do ECMO in autologous and allogenic patient. But we must recognize that these two categories have a transplant-associated mortality that is different, that is much more lower in autologous than in allogenic. So it is important to consider the patient that we are evaluating at the bedside. It is important also to consider the therapies that we are doing, because some patients receive immunosuppressive treatment to manage alloreactivity. Alloreactivity not only for the graft, but also to control the host versus graft. What about the platelet number in the decision? As you can imagine, in these patients, we cannot maintain the target level that we are used to see in the Red Book, by definition, because these are hematological patients. But for sure, even though we reach a weak agreement, we do not recommend the use of ECMO when there is refractory of transfusion for platelets. Giving us a definition for refractory of transfusion when we transfuse and we don't get what we want in terms of platelet counts. Other special population where we put the attention: when to stop. A patient receiving more than 2 hematopoietic cell transplantation that have already failed should not be considered eligible for hematopoietic transplantation. And this is important because increasing the number of transplantation, our patients receive also a huge amount of preconditioning before that can affect the outcome. Instead, we found a strong agreement for the use of ECMO in patients with poor graft function, considering poor graft function a trilinear dysfunction of white blood cell, red cell, and platelets. And in this patient, we have to pay attention. We should consider on a case-by-case basis if we can perform ECMO or not, according to the chances of recovery. Teamwork with the hematologist is important. I'm going to the conclusion for this part. It is important to have clear the targets in mind, accounted not only the doctor's experience, but also the family will, not only when, and the patient will, not only when we evaluate the candidacy, but also when we have the withdrawal. Engraftment. Engraftment in these guidelines has been a limiting point because we decided to divide the population in patient receiving ECMO before the engraftment and after the engraftment. Going fast on this, before the engraftment, there is really poor suggestion to use ECMO among the steering committee, but if you have a respiratory disease or a cardiac dysfunction induced by a bacteria, there are more chances to recover using ECMO in this phase. We absolutely contraindicate the use of ECMO in this phase when you do not have the engraftment if you have a viral or a fungal infection, because you need the T cells and the B cells to face this situation. After the engraftment, the situation is a little bit better because you can use different strategies. In particular, immunotherapies are the ones that in some centers have been developed, and you can use these therapies to overcome some viral infections that are frequent in this period. And so in this patient, after the engraftment, a case-by-case evaluation should be done because there are more chances to recover, not only for respiratory failure, but also for cardiac failure. Just a moment, in the adults there was a similar experience, a very short number of patients, but they found a temporal line where it is much more easier to go on ECMO after 24 days after the engraftment. It seems from this work that more far away, and it's obvious, you are from the engraftment, and more chances you have to recovery. But of course, the immune reconstitution after 240 days has really improved. And instead, what is happened to us is to give an opinion on candidacy early before, during the first month after the transplant. So it is not so much helpful, but it helps to understand that immune reconstitution has a time point, and at a certain point it is possible to give to our patient more chances to recover. General management of in ECMO for this patient, mechanical ventilation setting is the same for other patients. We don't have any data about this, so we suggest to use the ELSO guideline. Bleeding and thrombosis, careful attention to this, maintain a higher level of platelets during the ECMO run. We arbitrarily define 40,000 during ECMO in these patients, considering other works in oncological patients, and to maintain a lower level of anticoagulation with heparin or whatever you like, balancing the risk of thrombosis and bleeding. In particular, we suggest to use an high flow and to use a circuit that is limited in terms of stopcocks to avoid clotting over there. Renal replacement therapy can be used, of course, when there is fluid overload or acute kidney injury that cannot be managed with medical therapy. It is suggested to use to avoid complications related also to electrolytes and to hyperammonia that can happen in this patient. Just a small concept on lung transplant in this patient. Lung transplant is feasible in children that have complications like bronchiolitis, acute bronchiolitis post hematopoietic cell transplantation. Bronchiolitis obliterans, I say in particular, and it is possible to do a bridge to lung transplant after 2 years from the hematopoietic cell transplantation if your patient is free from relapse. And this was another concept that has been discussed and reached strong agreement. What we can say instead for immunoeffector T cells, we do not have any data at the moment of the use of ECMO in this particular situation, but if we consider that cytokine release syndrome or lymphohistiocytosis associated to CAR T cell are reversible with steroids or other therapies, it is important to consider the possibility of ECMO on a case-by-case evaluation, because each patient is different, and if this patient were able to be sustained and treated with CAR T cell, it is possible to consider eligible also for ECMO if there are chances to recover. Importance, and I'm going to conclude the registry. It is a call that we have done to ELSO to uniform and to open for an addendum of including this kind of patient that are so particular and require some more information. This will help to standardize pre-ECMO treatment and post-ECMO treatment. We do not have at the moment a good registry to collect this data, and further there is overlap between many registries, especially in US, and it's difficult to differentiate patients in one registry and in another registry. There are limits in these guidelines. The first one, I think, is considering the lack of robust data on this field, it is difficult to generalize recommendation in many hospitals. And in particular, we believe that centers performing a low number of hematopoietic stem cell transplantation, as well as a low number of ECMO, should be evaluated this guideline carefully, because some of these treatments that I mentioned before are not available in all centers, like adoptive immunotherapy and so on. Of course, in the next years, considering how fast the medicine in this field is going, these guidelines will need a revision for sure with the new data. I'm going to conclude, and I would like to thank a friend of mine that is not here, that was the leader together with me of this venture, and it was Chris Madeo from the Cancer Center of Houston, Henderson Cancer Center, and all my colleagues in Rome that are working for me when I am here. Thank you.
Our next speaker is the amazing Peta Alexander, who is one of the cardiac ICU pediatric cardiac ICU intensivists here in Boston, and a magician because she makes things appear out of nowhere. And she's going to talk about the PEACE Collaborative, which is the pediatric ECMO anticoagulation. So thank you, Peta.
Good morning. I am giving the update on behalf of Jennifer Mazinski and the team who've all contributed to the Pediatric ECMO Anticoagulation Collaborative. These are my disclosures. For any junior investigators in the audience, the senior investigators will already know this, getting the right collaborators for any project sets you up for success. And there is not a better collaborator, contributor, and professional in the world than Dr. Jennifer Mazinski. And I'm so sorry she's not here giving the update today. When we decided to take on the pediatric ECMO anticoagulation issue and the lack of consensus in this space, Jen basically threw down the challenge, and we brought together a group of people to lead 8 subgroups to target issues associated with ECMO anticoagulation. The group that are assembled with pictures on the slide have done an enormous amount of work over 2.5 years. That we've separated the issues into circuit and components related ECMO anticoagulation, as well as bleeding, different therapeutic strategies, different monitoring strategies. And the team that you can see here, along with 34 additional experts, have put in an enormous amount of work. And it's great to see Matteo's results slides up, because we're getting to that point. We're just finalizing the manuscripts. So our update today is going to be basically a couple of highlights for the things that we're really proud of as we're moving this forward. One of them is that we've had implementation scientists involved from the very beginning. They highlighted that just having consensus statements without actionable findings and without resources for units to use as they're managing patients in their own centres would not actually change the state of play. And so some of our groups have done a fantastic job getting together resources that I hope you can all use in practice. This is from Ariane Willems, Kate Steffen, and the group who managed anticoagulation during procedural support, so before, during, and after procedures happening on ECMO. And they've summarised this table of the statements that basically are summarised according to procedures that have been allocated as minor or low risk of bleeding, and then 2 high-risk categories, major procedures that are non-cardiac in nature, that would include things like CDH repair, and major procedures that are cardiac in nature. I haven't put all of the recommendations up on the slide, but you can see at a glance that the recommendations are either informed by guidelines that are informed by evidence in yellow, and evidence-based recommendations that are in blue. Not a lot of evidence informed these, but the idea of having something that was so visually powerful, we were quite impressed by. There's another version of the guidelines for the same group, the peri-procedural group, that includes the recommendations with green, go ahead and do this, or red, we'd recommend against this, because we recognise that many of the guidelines, many of the recommendations are quite wordy, and so we wanted to highlight it in a way that was visually appealing as well. We've also been working with the implementation scientists to give some visuals to the bleeding patient on ECMO or the patient with clotting complications on ECMO. And you can see that this is still in progress. I've got changes mapped on this picture. And the illustration's being worked up with the implementation scientists as we speak. Again, green for we recommend going ahead and doing this, red for just balance that up when you're ready. Oh, and I'm sorry, that was the thrombotic complications equivalent. One of the things that we were really proud of, and one of the biggest achievements out of the consensus group and expert panel, is going to be the research priorities that have been identified. I'm so excited that we'll be sharing these soon, but in the meantime, we're setting up to get people together to talk about how we address the research priorities as a community, and I've included the QR code here if you'd like to be updated, included, invited as we move that through. So please click on the link, send me your details, or otherwise reach out to Jennifer Mazinski or myself because we'll coordinate the effort again. We've got a couple of things left to do, including finalising the manuscripts. Again, Matteo, I can't imagine how much work you did to pull it through, but we're getting there. I don't have a date for the Research Priorities Summit, which is why I want you to click on the QR code. And solving all the world's problems will be pretty straightforward after we've tackled this. When we approached the Pediatric Critical Care Medicine Journal editor for his support when we were applying for funding for the Pediatric ECMO Anticoagulation Collaborative, he sent me the most fantastic email. And it was basically a long discussion of why we'd got the acronym wrong. He said, if you're actually thinking about tackling pediatric ECMO anticoagulation, your title needs to be War and Peace. You can't just call it Peace. But with the right team of collaborators, we've had a fantastic time doing this, and I'm really looking forward to sharing the results with you next time. Thanks.
Thanks, Peta. And not to be politically correct, I understand that Vladimir Putin is a little bit worried that Peta's coming for him next, so she could really do us a service. Our final speaker is Lawrence Lequi from Edmonton. Lawrence is the head of the unit there, and he was kind enough to be an editor on the 5th edition of the Red Book, and he's going to talk to us about long-term outcomes, which is really what we care about.
Alrighty. So everybody, thank you so much. last day, last session, last speaker. I can't believe everybody's hanging around. Everybody gets bonus points for this. But no, thanks. It's great to come in here and talk about neurologic outcomes, because something that, as you'll see, something that we're very involved in and I'm very interested in. And I think like most of what we do, no matter what we're talking about, anticoagulation or transplantation, we don't have enough information, and we really want to do what's best for our patients. So I have no disclosures. I'm hoping to review what outcome literature there is, what's been done in the different sort of age groups and disease categories for long-term neurologic outcomes that's just beyond survival. And I hope that kind of by the end of the session, you have some idea of some discussions you might want to have at your own center of what's possible, what you can do to augment and expand the information that we have on these patients and follow them up. And really what we want to do is get to a point where we can identify the patients that are at risk and get services and supports for them to help them become their best long-term patients. Okay, so as you heard yesterday in the session, that neurologic outcome is really challenged potentially in neonatal and pediatric patients for lots of reasons, whether that's their underlying physiology and the complex surgeries and everything that goes into it. Adding to that, putting them on an ECMO system is making it even more challenging and more complex. So there's not a lot of information out there on long-term outcome. A lot of it is POPC and PCPC, which is sort of general standard scales of how patients do, but it's a lot of what I think a lot of us are forced to do because we don't have more information available. It is valuable though, any outcome data is valuable. And there are lots of stores and studies that look at patients, including this recent one from the UK, where they looked at a whole bunch of studies piled together for over 700 patients and saw that the majority of the patients have good to mild to moderate disability outcomes, and that's really important. And I think we need to get a little bit more granular, though, to help our patients to the best that we possibly can. So ideally, I think we would like to do long-term neurologic follow-up similar to what really has been done for neonatal follow-up for many years. And if we look at that, so that's the first group that I want to discuss, and this is kind of neonatal neurologic outcomes, neonatal ECMO outcomes. There's lots of data on this. This is sort of the biggest group of patients that have been followed. This is the oldest group of ECMO patients, obviously. There's lots of them to be followed. And some consistent things have been shown, and that is that IQ is generally within average range. Behavioral problems, attention deficits, things like that are pretty common. But for the most part, patients do fairly well. They need sort of structural follow-up, and they need sort of significant input, but they can make really good achievements, even though they will often need more help in school than obviously their schoolmates and other counterparts well known. There's less information on pediatric patients, and so the group that we have sort of non-just respiratory neonatal patients. So the group that the most information is available, though, are pediatric, neonatal and pediatric cardiac patients that have been evaluated. And I think that's because for most of us in most of our centers, this is the biggest non-neonatal group of ECMO patients that we take care of. So this is our own center looking at data. Our initial 5-year cohort looked at data. We're really lucky we have something called the Western Canadian Pediatric Complex Therapies Follow-Up Program, and what that does is we get referrals from multiple centers within Western Canada. We perform complex therapies. The survivors get sent back home, and we've organized long-term neurodevelopmental follow-up in their home centers where the referrals came from at patients at 6 months of age, 2 years of age, and 4 years of age, and that's the data that we're presenting. And no patients are seen after age 6 because all the funding for those children is in school, so we don't have access to those patients. So what we saw in our initial cohort of five years of cohort was that about half of the patients have mental delay, but that about half of the patients do good long-term outcome. We did a longer 10-year cohort, and what we saw was similarly, about half of the patients have mental delay, but importantly at the very bottom, you can see there's the worst of the patients with CP are very few, and that the majority, almost half of them, have no significant neurologic concerns, which is great to see. I think it's very encouraging. We also did the same thing looking at a 10-year cohort of any patients that had received ECPR in our center. We ended up having 55 patients. 4 of them were non-cardiac eCPR, no survivors, not surprisingly. We've all learned now that those are patients that have a challenge to survive. So if we just look at our cardiac eCPR, over 50 patients, we saw that approximately half of those patients are discharged home. And so that's a terrific finding. I don't think we all would have thought that that was possible with a very, very complex group like eCPR. And we saw that the ones that did have higher mortality, the longer your CPR duration, the higher the amount of blood products you used, and certainly your initial lactate and how long it took for your lactate to come down to less than 2. Of the survivors, we did long-term neurologic follow-up on 17 of the survivors and showed that no matter what measure we used, whether IQ measure or motor measure, that we saw that patients were within 2 standard deviations of normal, but as you see, they're skewed slightly to the left from what we would see in normal patients. Similarly, the THAPCA trial did a nice evaluation of neurologic outcome, and I think it's nice that a lot of the studies that we're now doing are including not just survival but neurologic outcome, and that's what they did in the THAPCA trial, looking at 12 months of patients and looked at patients that had eCPR, no eCPR, and VADS, and saw that no matter what group you looked at, they had similar neurologic outcomes. And again, at the bottom, I think it's very encouraging to say that the majority, over 60%, had no significant neurologic impairment. I think there's now increasing amounts of information, especially adults are doing like a health-related quality of life analysis, and some of their patients, Matthew Schmidt in Paris, I think has done an amazing amount of that work, and I think we're starting to do that same stuff here in PEDS. So we did a 10-year cohort of health-related quality of life. We used the PEDS QL at follow-up. It's a parental survey that parents take because most of our patients can't do surveys. And what we saw, it was interesting that about half of the patients were survived to be followed up, and that the majority of them fell below normal compared to normal healthy volunteers would be normal, which we would expect, and that the older the patients, the better that they were doing. Similarly, an HRQL study, health-related quality of life study from Germany, all mechanical cardiac support patients of varieties of types over a number of years, and saw similarly that about of the look at the long-term survivors, that the survivors were not as scored as high as healthy controls, but that the older and older the patients got, the better that their outcome scores were. Something called the functional status scale came out recently, and I think it's a terrific way for us to sort of a surrogate marker for neurodevelopmental outcome. It's similar to the PCPC, but it's a 4-point scale. And this is a study by 8 separate centers over 2 years, over 500 patients. And what they saw was that the majority of the patients fall in the good categories, and that the worst outcomes are correlated with things like we would expect. So if you were a neonate, if you had congenital chromosomal disorders, or in the pediatric patients, if you're more chronically prior to being on ECMO, you're going to have a worse outcome afterward. And so I think those are all things to expect, and I think it's hopefully something that we'll start seeing used more and more for patients that don't have the long-term neurodevelopmental clinic follow-up. I wanted to just throw a couple other ones out there. There's a group that was looking at correlating MRI findings to some survey findings, and they did that with over about 5 years, looking at 30 patients. Now, the majority of these were neonates, so it's essentially more neonates than anything else, but definitely showed that correlating MRI findings, MRI complications to ages and stages questionnaire, there was a significant correlation. And so about a third of their patients had developmental delay, and that most of those patients recommending that you want to maybe screen for those patients looking for MRIs prior to discharge, and I think that's a great recommendation that's come out of this study. Now, there's probably, if you look at, like I said, neonatal and cardiac patients, there's emerging data, but if you look at the ECMO after respiratory failure patients, that's the group that probably has the least amount of data available. I think it probably has to do with the fact that for a lot of us, it's our smallest group of patients, so there's only a few number of patients in each center per year, and so it's hard to follow them up over a long period of time. And so a lot of those are lost to follow-up as a consequence. And so this is a recent UK study where they looked at almost 100 patients and of pediatric respiratory patients, 200 patients, and saw that trying to follow them up, over a third of them were lost to follow-up, but thankfully only about a third of them had significant neurologic concerns, and the majority of them that they saw did not. So I think that we're in a time where we need some more information, and that's why I'll just mention again, I know Ryan talked about his talk, the ASCEND study. I think this is going to really, including not only survival, but significant neurologic outcome surveys and questionnaires at the end will be very, very helpful. And I'm glad they're doing that with all the 500 patients and the 100 centers. And I think we're going to get a terrific amount of data in this particular population from that. So good luck to Ryan, and good luck to all the ASCEND centers, including our own. Finally, I'll just like to acknowledge one person, Dr. Charlene Robertson. She's the developmental pediatrician at the Stollery who has coordinated all of these outcome follow-up clinics for the past 3 decades. As I said, the complex therapies performed in our center, but she's coordinated follow-up and neurodevelopmental follow-up clinics in 4 other pediatric centers where our referral sites come from. So it's a huge undertaking, and she does a great job of it. I'm really lucky that she's led the way for us for over 30 years. So none of this here is from me. This is all from her. We appreciate to be part of that. And then finally, as I said, last speaker, last talk, thanks for the invitation. Kara and the scientific committee, thanks for inviting me, welcoming me, and thanks to all of you for coming to a great meeting, and I'm glad that it's growing and growing, and hopefully we'll see you guys next year in Seattle.
I'd like to thank all of our speakers for a really great session. We have about 9 minutes for questions. So I invite your questions. Please come up to a microphone, and it would be great if the speakers could come and join us on the stage. Okay. June, go right ahead.
Hi, I'm June Teruya from Houston. I have a question for Dr. DiNardo. Thank you for the very informative presentation about stem cell transplant and ECMO. You mentioned about cytokine release syndrome. So, as you know, cytokine release syndrome is known to be associated with a very severe low fibrinogen. So, in the setting of ECMO, how do you manage those patients with a continuously low fibrinogen?
Okay, in general, in this recommendation, we suggest to maintain a normal level of fibrinogen, supplementing, and antithrombin. So, having no data about this, the steering committee suggests to maintain the normal milieu environment that normal people have during ECMO. So supplementation is what we suggest also in this situation.
So because of the very rapid decrease of fibrinogen in the setting of CRS, it is very difficult to maintain the appropriate level. So you may be giving a cryo or fibrinogen concentrate continuously, or how do you manage those patients?
The best approach that we said is to give boluses of fibrinogen. In that specific scenarios, my experience at bedside, not in ECMO, but with CRS, because I treat several CAR-TC patients in my unit, we do not have such big issue with low fibrinogen. I mean, the fibrinogen is low, but between low platelets and low fibrinogen, I think that the balance is between low platelets in these patients. So I think that if you try to maintain as much as you can, value of fibrinogen over 150, if you can, while maintaining a good level of platelets during ECMO and good level at least over or around 40,000, I mean, you achieve your goal. And you also have to consider that the cytokine release syndrome is something short. It doesn't last weeks. If you have the right therapeutic approach with steroids, with tocilizumab, and so on, you can contain the burst of cytokine release that is different from the one that you are used to here in COVID, for example, that is maintained by the other mechanism. In CAR T cells is due to the release of specific cytokines that you can control, in particular the IL-6.
Okay.
Come on, all you smart people out there, there's not one other question. Well, I will take then the chair's prerogative to ask Dr. Koenig a question about tracheostomy. Do you have a sense of why we are so low in the pediatric population? Is it we're just uncomfortable with that, or do you think there's resistance from the families, or it's a multifactorial issue?
I think it's probably different at every center and with every patient, and I think it was kind of going into this, it was something that I was expecting to make an argument that we should be doing more of. And I don't know, kind of based on the available literature, that I would say that that's something that I've truly kind of come to believe or decide that we should be doing more tracheostomies in pediatric ECMO. I think certainly for the right patient, it can facilitate a more wakeful state that I think can, everything I believe about pediatric critical care is an awake, calm patient with a supportive family and team is going to be the right target if we can get there, and a tracheostomy may be that tool. But I think it's certainly not right for every patient, and I think we also see more success of getting patients extubated without potentially needing a tracheostomy. And so I think potentially that experience is maybe pushing us to doing them less.
The good Dr. Onek from Toronto.
I just to sort of talk about Joe's point, and I'm glad it's being presented. One of the things I found with children, especially toddlers and a little older, they're not very compliant when you want them to cough or with pulmonary toilet and things like that, where you need to start to clear their secretions. So my sort of gestalt when I look at those sort of awake patients is if it's safe to place the tracheostomy, I do, because then I can always have that access to the airway. But I don't necessarily feel the need that they have to be on a ventilator. And one of the things that we do much more, almost routinely at Sick Kids is that all of our patients, the smaller ones, are nasally intubated. So again, you can give them a soother or pacifier, or whatever word you use, and you can give them some other things that make them more comfortable. And I don't think we've seen any increase in bleeding. So I think there's a few things to consider in the pediatric population, in the range that we manage them at. Because if you get an older, more compliant patient, then that might be good to extubate them. But in some of the younger ones that are kind of a little bit of brats, it's kind of more tricky.
Thank you. Okay, we're probably pretty close to the end of the session, so I will take this opportunity to thank Dr. Kara Agastron and her team of organizing committee, and we really appreciate a wonderful meeting. If you see her, thank her. This is a lot of work to do these meetings. Again, the next session is the last session. It will be here in this room, and it will be Dr. Bartlett and Dr. Onek talking about the history of all of this craziness that we do. Thank you all very much for your participation and your interest, and we'll see you in Seattle, if not in Keystone before.